I think it's easier to start with the supraclavicular and then we go up into the interscalene before we go below the clavicle. So the supraclavicular block was introduced early in the 20th century in Germany by Kuhlenkampf, and in 1928, this is the original publication, 1911. It's in German. I don't understand a thing, but I think it talks about the block. And here is the publication in English in 1928. He already have produced more than 1,000 blocks, and unfortunately, a number of pneumothorax, which eventually will be the reason why supraclavicular ended up being almost dead, and it was kept alive in ICU in a few centers, especially here in the U.S. One of those was Cook County Hospital. Although it was called differently, I think it was called subclavian perivascular, but it was the same thing. So eventually, supraclavicular was resuscitated thanks to the help of ultrasound. We never abandoned that block, and it's still a workhorse here. And it should be. There are many reasons why it's the best block in the entire regional anesthesia armamentarium. Now, as I mentioned, the supraclavicular block is performed at the widest portion of the interscalene space. You can see how the arrangements of roots from top to bottom originate trunks, and the trunks originate divisions. Notice how the upper trunk here is originated in the upper, the anterior, and the posterior divisions, and then there is a stack of divisions underneath, which correspond to the middle and lower trunk. And notice how the suprascapular nerve, I'd like to think of it as the third division of the upper trunk. So instead of just talking about 6 divisions, there will be like 7 divisions, one coming from the upper trunk. They have the same dimensions, and you can see that when you think in those terms, it will be easier to recognize them within this myofascial compartment. So the floor of this compartment will be the first rib. Now, the medial wall of the compartment, instead of being the anterior scalene, since hopefully you're not planning to enter the subclavian artery, is the subclavian artery. Now, the subclavian artery becomes one of the most important landmarks because it's so easy to see. So the subclavian artery becomes the medial wall of that compartment. The lateral wall is the insertion of the middle scalene, and the upper, or the ceiling, is the prevertebral fascia. And usually you see the omohyoid, as you see in this image here. You see the omohyoid is sliding on the fascia. So the omohyoid presence allows to see the ceiling of the fascia, or the roof of the fascia, or the roof of the compartment much better. But to tell you the truth, the roof of the compartment is the least important. The two most important would be the medial wall, which is the artery, and the inferior wall, the floor, which is the first rib. If you have those two, you can still work, very well, because you will go to the corner between these two structures, what has been called the corner pocket. So the compartment has different shapes dependent on how the middle scalene inserts on the first rib. So if it inserts very close to the artery here, the stack of divisions will have to be pushed up, and so it acquires the shape of a mushroom, but the concept continues to be the same. You have a compartment posterolateral to the artery on top of the first rib, and that is what it really matters when you are doing this type of blocks. So now, when you think of the supraclavicular block in terms of the compartment, now you have the whole solution to the problem of how to get it right. Because now you will drive a needle, and you will know that inside that compartment, there's 7 nerves. The 7 nerves carry the entire sensory, motor, and sympathetic innervation of the upper extremity. You will never find a book that you said that you read, that your uncle had, that his grandfather had given him, and it was in page whatever, said that there was a nerve that goes around and eventually get to the upper extremity. This is the way to get to the upper extremity from the neck, or this is the way to get from the upper extremity to the neck. So this is the only passage. So when you realize that, you see the impact of this concept of the compartment. Because now you know that if you drove a needle into that compartment and injected an amount of local anesthetic, that experience will tell you will be sufficient both in quantity and density, then you should get an upper extremity block, with the exception of none. Notice how powerful that concept is. Keep that in mind. Now, just a word of caution that in our literature, injection inside the plexus is considered to be intraneural. That shows how ignorant we are. The nerves inside the form plexuses have funny names, but they're individual names. For instance, when you're doing an axillary block and you see median and ulnar nerve in proximity, you have no hesitation to put a needle in between and try to, as fun, to separate them, because you know they're two individual structures. Here is the same concept. These nerves have funny names, but they're individual nerves. So when you said, when you're trying to inject between the anterior division of the middle trunk and the posterior division of the middle trunk, you should understand that you're separated into individual nerves. So those nerves are inside a compartment. They're very close to each other, but there are individual structures. So you could inject in between them, and obviously the only way to get a brachial-plexus block is to invade the compartment, to get inside the compartment to inject, local anesthetic. So please don't be confused with the intraneural aberration. The patient position, when I got to regional about 30 years ago, all the blocks were done supine. All the blocks were done not only supine, they were done without a pillow. And then the pillow was used to make some type of a torture device to be put between the scapula so the patient could lay somewhere like this. Why that maneuver will help anybody, I don't know. But I suspected that this whole thing started by Dr. Winnie, who practiced in a wheelchair. So he could not stand up to do the block. So obviously with the patient flat in front of him was much easier. I'm just suspecting, I don't know if that was the real reason. I said this because if you look at pictures of the old time when blocks were introduced, they were all done in the sitting position in dental chairs. So, so this fact of putting patients flat supine, I think it started later in the 20th century. But for whatever reason, I always thought that sitting the patients was much better. And I have, for the most part, do most of the block in the sitting position. So I don't know if you recognize, this is Keith, our chief resident. He came shaved that day, impeccable, to get his pictures taken. And this is another one of our chief residents here, David Bolt, who is in California now. So we want to start this with the shoulder down, the head turned the opposite side, and the probe parallel to the clavicle. But not just anywhere in the clavicle. We want to do it on top of the sternocleidomastoid, the clavicular head of the sternocleidomastoid. Why? Because here's the sternocleidomastoid, because right underneath, separated by the subclavian vein, would be the pleura, the dome of the pleura. And you always want to acknowledge the dome of the pleura, and through the dome of the pleura, by traveling lateral, find the transition between dome and first rib. You know that both would be hyperechoic lines, but one would be more superficial than the other, the first rib, and that more superficial line will project a acoustic shadow. So that way, you will recognize the first rib as such. So you will label it and said, this is for sure the first rib, as opposed to just going directly and say, oh yeah, there is the first rib. So acknowledge the transition between the pleura and the first rib, and then call the first rib. So notice how you start building the image of the compartment. And once you get to the first rib in a position more lateral than you started, so you started there over the clavicle head, and now you're displacing the probe laterally, but always leaning against the clavicle, because that way you will have a stable probe, and you won't have to be looking down whether you are parallel to the clavicle or not. So, and here you see the subclavian artery, then you see the compartment made by the subclavian artery, the first rib, the shadow of the insertion of the middle scalene, and you see the prevertebral fascia, and sliding over, you see the omohyoid. So now, this compartment contains everything you need to block. So notice that ultrasound is so good to see things that sometimes we're not able to see a naked eye. But more frequently, ultrasound fails to see what you will see very clearly under a naked eye. I explain myself. Each nerve, now we know there are 7 nerves there. Each nerve is composed not only of neural tissue, or arranged into fascicles, but also has connective tissue. So connective tissue that's intrinsic to the nerve, and that connective tissue is more fibrous in the periphery, produces a skin to the nerve, and that is the epineurium. But now in between nerves, there is also connective tissue. So now the same material that is part of the building block of a nerve, it occupies space between nerves. So that blurs the image. So now you know, or at least you should know now, that there are 7 nerves located there. Now you can't call them exactly one by one and say this is one, this is the other. But you can do a pretty much educated guess if it came to that. You will say, for instance, that the arrangement of nerves closer to the artery will have to be anterior divisions. And the one most on top here will have to be, perhaps these 2, anterior division of the upper trunk. Won't be just, too much of a stretch to call that the anterior division of the upper trunk. And by the same token, the one located down here, closer to the rib and to the artery in that corner, that would have to be the anterior division of the lower trunk. So it won't be too much of a stretch to imagine that that would be the case. And then the ones that are closer to the middle scalene will have to be posterior divisions, and the one in the upper corner will have to be the suprascapular nerve. So, because the suprascapular nerve happens to be the most lateral division, we call it, of the upper trunk. So you could then verify if this is indeed the suprascapular by just following the omohyoid and see if that nerve follows the omohyoid underneath in its way to the suprascapular notch. So you can actually just topographically get a pretty good educated guess as to what nerves are. But it really doesn't matter, as I was trying to explain to you, that now you recognize that that space contains everything you want to block. Now it's just a matter of bringing the needle into that space and injecting local anesthetic into that space. So that's how I conceptualize this in my head, and that's why I don't chase nerves. When sometimes I come to load my local anesthetic there and I see a team there chasing a nerve that is, in the upper corner of the screen, and then there is another one that is over here, don't chase the nerves. Just look for the compartment, inject your local, and just realize that the local will find all the nerves that are necessary to find. As much as when we do an epidural, we recognize that we are in the epidural space, and then we inject a volume of local anesthetic that actually reaches your targets, and it will be volume dependent.